as well as psychiatry and behavioral sciences. And it's my pleasure today to introduce our speaker, Liz Klass, who will be talking with us today about treatment of tobacco dependence in patients with cancer. So Liz is our clinical operations manager. She's a nurse by training, and Liz joined the tobacco cessation program almost 2 years ago. And so Liz was really involved from the ground floor up in terms of designing the program, working out operational flows for how we were going to get our referrals, how we were going to treat patients in the cancer clinics. And on top of all that, Liz is now working really hard to expand the program to all of the regional cancer centers in the North, Northwest, and Western regions. So Liz is really busy. And on top of that, Liz is actually working toward her doctorate in nursing practice degree on the side. So she will soon be a doctor as well. So Liz has really become a truly an expert in this field. The NIH and the National Cancer Institute have relied on Liz pretty heavily during the development of this program to sort of establish some best practices. So Liz, in a pretty short period of time, has truly become one of the leaders in this field. And so it's really my pleasure to get to work with Liz and to call her my colleague and friend. So I think you'll enjoy hearing her speak today. And with that, I will turn it over to you, Liz.
Oh, thank you so much, Tim. And good morning. Thank you everyone for joining. I'm really honored to be able to present today for Grand Rounds and to talk about the importance of treating tobacco dependence in patients with cancer and to share some of the evidence-based best practices we have for doing so. So as Tim mentioned, I work with the Lurie Cancer Center Tobacco Cessation Program. That's part of the Supportive Oncology Department led by Dr. Pearman. And then on the university side, I work with Dr. Brian Heitzman, who's a tobacco researcher and associate professor in the Department of Preventive Medicine. So I'm really excited to share some of the work that we've been doing here at the Cancer Center in terms of improving tobacco dependence treatment. And I'm also going to share how this work fits into kind of a larger national push to begin to treat tobacco dependence as part of the to begin to incorporate it in the comprehensive oncology care model. So thank you again for joining. Let's see, I have nothing to disclose, just some housekeeping things. Please use the chat function if you have any questions. We'll have time for those at the end. And then if you are joining for CME credit, you can text this information to that number, and that information is in the chat as well. So today I'm going to talk a little bit about the prevalence of smoking in our cancer patients and share some of the characteristics of this subpopulation. I want to go over some of the impact that smoking has on cancer treatment outcomes. Tim referenced the National Cancer Institute's Cancer Moonshot Cancer Center Cessation Initiative, which our team here at Northwestern participates in. So I want to share some of the work that that national coalition has been doing. And I'm also looking forward to sharing some of the preliminary outcomes that our tobacco cessation program has seen since about year and a half since we first launched. So the fact of the matter, the heart of the matter, is really that upwards of 30 to 40% of individuals continue to smoke after a cancer diagnosis. So this statistic comes from a systematic review of about, I think, 130 pertinent papers, and it found that if you look at the cancer population as a whole, about 33% are current tobacco users. And then when you look at those who were using tobacco at the time of diagnosis, the mean prevalence is about 58%. So the issue is really pretty widespread. And this figure shows a breakdown of current and former tobacco use among different tumor types. This data is from the NHS, but we see similar trends here in the US. But this is just a nice visual representation, and it shows that while there is some variation between smoking related and non-smoking related cancers, um, the prevalence of smoking is really pretty common across all disease types. So it really warrants treating tobacco dependence for all cancer patients, especially since it has an impact on outcomes. So of course, we know that smoking has adverse health impacts, and that's been well established for decades, particularly the fact that it's a major risk factor for many types of cancer. But in 2014, the Surgeon General's report came out with the health consequences of smoking, an update on 50 years of progress since the 1964 Surgeon General's report. And this really heralded a shift in clinical care in cancer patients. And because it demonstrated that smoking after a cancer diagnosis is associated with both increased cancer-specific mortality and increased all-cause mortality. So this demonstrated that, this is no longer something that should just remain in the domain of primary care. This is really something that oncology providers and cancer centers should begin to address. It also showed that there's suggestive evidence that for a causal relationship between smoking and increased cancer treatment-related toxicity, increased risk of cancer recurrence, reduced response to cancer treatment, particularly radiation. And there's sufficient evidence that quitting smoking improves prognosis and reduces the risk of second primary cancers. And the way that I often translate this for patients who participate in our program is, quitting smoking will help you get through your cancer treatment more safely and more comfortably. And that's pretty convincing for a lot of our patients. And the reason this is such an issue is because cancer survivors are a growing group, partly due to our aging population and partly due to improvements in screening for certain cancers and advancements in treatments. We can expect to have more cancer survivors in our population. So at the beginning of 2019, there were about 17 million cancer survivors in the US, and that figure is projected to grow to over 22 million by 2030. So it's a big portion of the population. So for the next couple slides, I'm going to share some data from that came out last year in the Journal of Cancer Survivorship. And this showed some of the patterns and behaviors related to smoking that we see in cancer survivors. And it highlighted some interesting things. So about 50% of cancer patients report that they are interested in quitting. Only about half report that they've made a quit attempt in the last year. And surprisingly, only 65% of patients reported that any healthcare provider had advised them to quit smoking in the past year. Now, when we look at the ways that patients do try and quit, we see that evidence-based treatment is vastly underutilized. So the most effective way to quit smoking is through a combination of medications and behavioral counseling. However, less than 8% of cancer patients use both of these when trying to quit. If we look just at medications, about 37% report that they have used medications to quit, which is slightly encouraging. But then when you consider that over 60% are trying to quit cold turkey, which on any given quit attempt has a success rate from about 3 to 5%. That's not very good, especially in this population, which tends to have pretty high nicotine dependence. And furthermore, it's worth noting that nicotine replacement therapies like the patch, gum, lozenge, those over-the-counter medications are often really underutilized by patients when they do use them to try and quit. So there's a lot of room for improvement here on our end. But the good news is that the treatments that we do have for smoking cessation are safe and effective in this population. So Dr. Heitzman partnered with Dr. Schnoll at the University of Pennsylvania on this randomized controlled trial, I think back in 2017. And what it aimed to do was to compare cessation outcomes and adherence between the standard 12-week treatment of varenicline and an extended 24-week treatment with varenicline. Varenicline with the brand name being Chantix. So just for reference, here's the design of the study. So participants were randomized into one of the two treatment arms, either this extended treatment with varenicline for 24 weeks or 12 weeks of varenicline plus 12 of placebo. And then all participants received 7 sessions of behavioral counseling and follow-up up until week 52. And here we have the results from the study. It is a lot of information, so I'll kind of break this down. But for this study, we measured abstinence in 2 ways. The first was with continuous abstinence from weeks 9 to 52, which you see on the top 2 charts. And the second measure was from 7-day point prevalence, which we see on the bottom 2 charts. And 7-day point prevalence, really that basically that means from the time of assessment, did you smoke at all in the past 7 days? And starting from the bottom 2 bars on each chart show the 2 treatment arms, the blue being the standard treatment and the red being the extended treatment. And if we just look at those, we didn't see any difference in quit rates at weeks 24 and 52. However, we then broke it up into and looked for adherence. So the treatment arms that were adherent to medications are represented, the teal being those who were adherent to standard 12 weeks of treatment, and the orange is those who were adherent to 24 weeks of varenicline. And we saw some pretty good cessation rates. So if you adhered to medication, you were slightly more likely to quit if you were in the extended treatment group. We also didn't notice any increase in adverse events between either treatment arm, so that was encouraging. With this data, we also looked for any changes in health-related quality of life related to treatment engagement or cessation among these patients. We didn't see any improvements in health-related quality of life, but we didn't see any decline either. And this may be reassuring for some providers who are concerned that smoking is a necessary coping mechanism, or that a cancer diagnosis just isn't the right time to quit. We didn't find that. So just to summarize, we've seen a few things. We've seen that smoking is pretty prevalent in this population, that patients are interested in quitting, and that treatment is effective. And the 2014 Surgeon General's report really encouraged for this to be for tobacco dependence treatment to be provided as an aspect or as a core component of cancer treatment. However, historically, cancer centers and oncology providers haven't done a great job of doing this. Oh, sorry, I think there was a bit of an echo. Okay. So this data is from a survey of 58 NCI designated cancer centers in 2013. And what it found was that only 60% reported that they were routinely providing cessation education materials to patients. And only half of those cancer centers even reported that they were effectively identifying tobacco use in their patients. And those are just the two beginning steps. So there really was a lot of improvement to be made. Now, to address this gap in care, as part of the Cancer Moonshot program, the National Cancer Institute established the C3I Project, the Cancer Center Cessation Initiative. So this project, it aimed to fund tobacco researchers and oncology providers, and it funded 42 cancer centers across the country. Here at Northwestern, we were in the second cohort of sites. And what this project did was it tasked sites with either implementing a tobacco cessation program where there previously was none, improving existing tobacco cessation efforts at their cancer centers, or using integrating technology into the EHR to improve referrals and actually get patients connected with treatment. So as I mentioned, we were really lucky to be funded as part of the C3I initiative. Dr. Platanius is the PI for this grant, and he has been a really great supporter of our program from the outset. Dr. Heitzman and Dr. Pearman are both the project directors for this, as well as the co-directors of the tobacco cessation program. And so with this kind of injection of funding, our program was able to launch in June of 2019. And it's just been a really nice project to be involved with, because there's a real collaborative spirit. And with this C3I project, all of the sites gather twice annually to share successes and lessons learned. And it's just been really interesting because each site sort of took a slightly different approach that was informed by any number of factors: the size of their cancer center, the size of the smoking population, support from leadership, or the kind of EHR that they had. So it's been really interesting to see kind of how a variety of different models were implemented, all to achieve the same aim. So on the whole, the mandate from the NCI was pretty straightforward, and it was to take a population-based approach to this problem. So what we were tasked to do was to find a way to assess and document tobacco use in every cancer patient at every visit, to deliver some form of treatment to everyone who uses tobacco, and to, if possible, leverage the EHR to create and use a tobacco registry so that we can really monitor this population as a whole, and have sort of ongoing and repeated outreach and engagement efforts. So here we have our core tobacco treatment team. Apart from myself, we have two other tobacco treatment specialists. Emma Parrish is our health educator, and Sarah Clark is our new behavioral counselor. Julia May is no longer with us, but she was really instrumental in getting this program up off of the ground last year at the Cancer Center. Dr. Pearman and Dr. Heitzman are the project directors, and then clinically we are supported by Dr. Sheetal Kircher, who is our supervising physician and has been really kind of crucial in helping us get the word out about this program among other providers. So this diagram shows our clinical and referral workflow, from identification of patients to outreach to treatment engagement and follow-up. So you'll see kind of in the first column that we implemented a number of different referral pathways. On the patient-facing side, we utilize a patient-reported outcomes tobacco use questionnaire. So any patient that completes this in MyChart or in the clinic and reports using tobacco in the last 30 days is then automatically referred to our program. Any oncology provider or oncology staff member can also refer patients directly to us. And then on the population health management side, we worked with the Epic Healthy Planet team here at NM to create a tobacco use cancer patient tobacco use registry, and that is kind of our population level intervention, and we use that to reach out to patients proactively if they aren't referred by other means. And then one of the things that sort of has contributed to our success is we have a somewhat aggressive outreach protocol. So we when patients are referred, we reach out to them immediately over MyChart with a MyChart message, and then call them up to 3 times to schedule an initial phone consult. Before COVID, we were also very present in infusion clinics and would drop in to see patients during their infusion treatments. And then, so we provide counseling, we recommend and order medications, and then we also connect patients. In addition to our program, we connect them with external resources in the community. And then also crucial to this is we check in with patients at 6 and 12 months to assess for relapse and to re-engage patients if needed. Our treatment and clinical protocols are guided by the NCCN clinical practice guidelines for smoking cessation. Dr. Heitzman is one of the editors of these guidelines, and they're updated regularly. So this really informs, by and large, our treatment practices. And here, this is kind of the nuts and bolts of the approach to smoking cessation that the NCCN guidelines endorse. And you'll see there are 2 first-line treatment recommendations. The first is combination NRT, combination nicotine replacement therapy. So that is the long-acting nicotine patch plus a short-acting form of nicotine, the lozenge, the gum, the inhaler. So combination NRT combined with behavioral therapy for at least 12 weeks, preferably for 24 weeks. And then the second treatment option is varenicline, also combined with behavioral therapy for at least 12 weeks and up to 24 weeks. And this combined with motivational interviewing and really kind of practical counseling for helping patients develop the strategies and coping mechanisms to quit successfully. So now I would like to share some of the preliminary outcomes that we've seen since our program launched in June of 2019, and these will cover up to September of this year. So what I'm showing you here, I mentioned a few minutes ago that we have free referral pathways. And what this figure shows is the reach and engagement from each of those referral pathways. And these are the two main outcomes that, that we really focus on, especially in this initial phase of getting our program up off the ground. So you'll see that out of the 951 tobacco users that we identified through the EPIC reporting workbench, we were able to reach about half of those patients. 513 unique patients were referred, and we were able to reach 448 of those. And then out of those 448 that we reached, we were able to engage 158 patients in treatment. And here treatment is defined as at least one full consultation visit, usually about 30 or 40 minutes with a tobacco treatment specialist. And this amounts to over 16% of the entire eligible population. Here at the bottom, I did show that we also were able to publish on our use of patient-reported outcomes as a referral and engagement tool. So if anyone is interested, I would encourage you to look at that paper. This is sort of one aspect of our program that has been unique among all of the C3I sites across the country. But now, I think it's worth noting that we have seen some variation in engagement rates among these referral pathways. Patients who complete that tobacco, who self-report tobacco use on that questionnaire or the screener, they have about a 45% engagement rate. And we do get a good number of patients that way. Our highest number of patients actually come through the PRO screener. But we see that with provider referrals, 71% of patients engage. And part of that may be due to providers screening out patients who aren't interested in quitting. But for us, this also really indicates the importance of that provider advising a patient to quit. Providers telling patients, it's important for you to quit, it will improve your treatment. That has a really big impact on whether patients can quit successfully and whether they engage in treatment. So that's certainly something that, as our program evolves, something we're going to continue to push and optimize. And then with the tobacco registry, we see a much lower engagement rate, about 14%, which might not look that good, but we have seen it as high as 20%. And it's worth noting that with the tobacco registry, we are kind of cold calling patients who might not be in active cancer treatment now, who might not be actively seen by NM providers. So sort of anyone that we can engage that way is kind of a boon. But it is our sort of fallback to make sure that we're reaching the entire eligible population. So 6 months after engaging in treatment, we contact each patient to confirm to try and confirm the treatment that they engaged in. 98% of our patients participated in behavioral counseling, and 84% of our patients used at least one smoking cessation medication. And this is really encouraging because we know that at least 80% of program participants are using evidence-based treatment methods to quit. We do also refer patients to the Illinois Tobacco Quit Line and to NCI smoke-free resources. We see a lot less engagement with these, but part of that is due sort of to missing data, and it's kind of difficult to confirm whether some patients actually did engage with these resources. But this is also certainly something that we're going to try and focus on and increase patient use of going forward. So at 6 months, this is also when we look at effectiveness. I will, as a caveat, this is kind of hard data to collect, just because, you know, as a reminder, tobacco use is a chronic relapsing disorder, and especially in our patient population who do have high nicotine dependence and high relapse rates, these things change frequently, which is why repeated assessment is so important. However, we have seen some really good results thus far. We've seen a 34% abstinence rate at 6 months. So what that means actually is that at 6 months, 34% of patients reported no tobacco use in the last 30 days. And many more, about another 30% or so, reduced either by cutting their daily cigarettes per day in half, or by becoming someday smokers instead of everyday smokers. So on average, treatment intensity varied according to patient need and patient interest, but on average, patients received 4 visits with our program, with each counseling session lasting about 20 minutes. We also conducted a patient satisfaction survey with patients, and I won't go into these too much, but about 93% of patients said that they were either likely or very likely to recommend this program to other patients who smoke. We also saw that about 84% of patients said that they agreed or definitely agreed that that participating in this program improved their overall care at the cancer center. So moving forward, we recently, in September of this year, our tobacco cessation team, our C3I team at Northwestern, we were notified that we were one of the 11 original 42 funded sites to be awarded an enhancement grant. So this is another year of funding to improve or expand our program in some way. And the way that we are planning to do this, and actually, in fact, what we've already started to do, is we are using this grant to expand our reach from the cancer center to the 32 other oncology clinics in the West, North, and Northwest regions of NM. And we're really excited about this. We actually, just last week, on December 1st, was our official launch date. So we have already started treating patients in the North and the Northwest. And you'll see, if you look here at the bottom, the patients documented as smokers, we see a bit higher smoking prevalence. There's about a 5% smoking prevalence in the central region, but that's a little bit higher in the West and North, quite higher in the Northwest, but that might be an anomaly. But we're really excited that we'll be able to expand to these areas of higher need. And as our program is growing, it's really worth noting that our tobacco cessation team is growing as well. And we've been really, really lucky to find great people to collaborate with in each of these regions. Everyone listed here, from oncologists to leadership to practice managers to nurse navigators to members of the IT team, have been really supportive and instrumental in helping our program expand into these other regions. So it's not only our program at Northwestern that's growing, but it's also worth mentioning that the C3I initiative as a whole is continuing as well. They recently funded a 3rd cohort of sites, and there may be additional cohorts after this, but one of the things that we're really hoping comes out of this is that altogether our sites will hopefully be able to create some models, some some technical guides, some implementation guidelines that can be used by other cancer centers and other community health clinics looking to, who are also looking to address tobacco dependence in their population. And this I wanted to mention, when COVID hit in March of this year, the NCI, they really quickly realized that they had this existing relationship with these 42 centers that have been participating in C3I, and we've really developed a good, there's a real collaborative spirit that goes along with this initiative. And so NCI realized that they wanted to leverage this relationship in order to take a look at COVID and see how smoking status might impact risk of contracting COVID, disease severity, or mortality. So this was competitively funded, and our site at Northwestern, we were one of 16 sites who are participating in this. And what we've been doing every month since July of this year is we have, on a monthly basis, we have been sending our entire pool of de-identified patient data to the University of Wisconsin, and they are actively taking a look at this data. We're hoping that something will probably be published in the next month or so. So we're really interested to see what comes out of this. But the last, these numbers are growing obviously, but at the last count, this cohort represented 300,000 COVID cases and 60,000 COVID hospitalizations. So this initiative, this COVID initiative, is actually one of the largest pool of data on COVID patients that we know of in the U.S. So we're really excited to see what they find in the coming weeks. And just to wrap up, I did want to mention that all of this work wouldn't have been possible without the critical funding that we received from both the National Cancer Institute and the Cancer Center. Additionally, it was not just our core tobacco team that accomplished this by any means. We really had the fortune of working with great teams across NM and across the university that really enabled us to build this program, to implement it, to make it a success, and to help it grow. And finally, I know there are probably some oncology providers and fellows and residents and nurses here, so it behooves me to make a plug and let everyone know that if you have patients who smoke and you want them to engage in treatment with our program, please send them our way. Any provider can refer through a supportive oncology order. You just click the tobacco cessation program, or you can send patients directly to our tobacco cessation pool in Epic. So with that, thank you so much. I'm happy to answer any questions, but thank you so much for taking the time to listen. Thanks so much. I don't know if there were any questions. Let me see. Emma, are you on?
I am on. There were no questions that came up in the chat, but could you pull up that 5-digit number? Oh, perfect. It's in the chat now. That 5-digit number to text for the CME credit.
Oh, got it. Yeah,
in the chat for folks.
It's in the chat. Okay, perfect.
Thank you everyone for joining today.
Thanks so much. Have a nice day. Have a nice weekend, everyone.